Good day. Thank you for joining our webinar today. Improving Interoperability, Things You Should Know About Health Information Exchange and Public Health Registries. My name is Selena Williams. I am the Program Manager for the Medicaid Promoting Interoperability Program at HIE Solutions. HIE Solutions is Georgia's Health IT Center for assisting clinicians in the redesign of healthcare delivery through the successful adoption of EHR technology in interoperable systems. Our goal is to assist you with successfully meeting the Medicaid Promoting Interoperability Program. We're located at Morehouse School of Medicine, National Center for Primary Care. Carmen L. Hughes is our Executive Director, and Dr. Dominique H. Mack is our Executive Medical Director. And we partner with several companies across the state of Georgia, DCH, Department of Community Health, GHIN, and several healthcare systems across the state of Georgia. Our presenters today are Ryan E. Spikes and Liz Hanson. For physicians who are eligible for the Medicaid Promoting Interoperability Program, our MAPIR portal is now open to start submitting your applications for payment year 2020. Our webinar objectives today is define health information exchange and how it applies to promoting interoperability. Review methods to succeed in health information exchange. Define public health reporting requirements and exclusions, and understand the actions required to meet the BI public health measures. I'm going to turn it over to Liz Hanson, who will present on the health information exchange, and Ryan Spikes. Thank you.
Thank you, Selena. Next slide. So today we're going to talk about the Health Information Exchange objective, which is Objective 7. We have a link on the screen that takes you to this specification. And I do want to point out that these first several slides will be specific to the Medicaid Promoting Interoperability Incentive Program. I think we have some folks on the line that are affiliated with the Medicare program or the MIPS program. And so as we get into the latter part of these slides, then we will talk about the subject as it applies to all the programs. But these first couple will apply to the Medicaid program. For the Health Information Exchange Objective 7, the EP, or the eligible provider, has to provide a summary of care record when transitioning or referring a patient to another setting of care, receives or retrieves a summary of care record once a transition or referral has occurred, and it can be a transition, a referral, or the first patient encounter with the new patient, which does become an issue if you are referring, for some practices, if you're referring within the practice. So we're going to address that in just a few minutes. And it also includes a measure for incorporating the summary of care information from other providers into your EHR using the function of your certified EHR technology. I want to just stop for a minute and talk about Health Information Exchange, the phrase. Health Information Exchange, or HIE, for the purpose of this objective, and most of our discussion today, although we will mention the other kind, is an action. So it is the action of exchanging data electronically in the healthcare world. Of course, we're exchanging medical record data electronically. HIE can also be used to refer to the infrastructure that supports the exchange. For instance, the HIE for the state of Georgia is GHIN, which is the Georgia Health Information Network, and that is an HIE. We have an HIE with high bridges, and there are other HIEs that are available or around within the state, but we're not specifically initially talking about the noun HIE. We're talking about the action or the verb, Health Information Exchange. Next slide, please. I think I made that just as complicated as I could. So the three measures. For these three measures, an EP must attest to all three measures and meet the threshold for two measures for this objective. Folks, I'm going to go over this maybe a couple times. We had a lot of questions around this last year. we had a great many people who couldn't submit because there was some misinterpretation, perhaps on the practice side from this measure. So we just want to make sure it's perfectly clear to you and invite your questions if not. Now, with that said, I'd like to read, point out that what is not acceptable. It is not acceptable to exclude one of the measures, meet one of the measures, and fail one of the measures. That is not a passing effort. Again, meeting one measure, excluding one measure, and failing one measure is not accepted as passing this objective. You can meet two and fail one, or you can meet two and exclude one, but you can't meet one, exclude one, and fail one. Okay, so for this first measure, just going to dissect this. Actually, we're going to dissect this a lot, folks, because a lot of the problems we're seeing are actually covered in the specifications, but very few of us want to go read those specifications. So by George, we're going to go over those specs today. So measure one, for more than 50%, and remember, it's always more than, not equal to, more than 50% of the transitions of care and referrals that the EP transitions to another setting of care or a provider of care. Okay, so it could be outside of this practice, or it could be the same practice, a different provider of care. Creates a summary of care record using their certified EHR technology and electronically exchanges the summary of care record. Electronically exchanges. A fax is not considered an electronic exchange. An EP can take the exclusion if either or both of the following apply. If the provider transfers or transitions fewer than 100 times during the reporting period, or conducts 50% or more of their encounters in an area that does not have acceptable broadband availability. Now, this last portion, folks, is not at all based on how you feel your internet connectivity is, or whether it's flaky half of the day, or whether your patients use the internet, or whether your referring providers have poor internet. It's not based on any of those things. It's based on whether the FCC has declared that your area does not have acceptable broadband. Okay, and there is a list, and there are very, very few areas in Georgia that are on the list. If you have a question, we'll be glad to help you look. But by and large, most of you are not going to have that as an exclusion. For the measure two, for this objective 7, you must have more than 40% of transitions or referrals received in patient encounters in which the EP has never encountered the patient before. You are incorporated into the patient's record. So in other words, for more than 40%, when you receive in the summary of care records, you must incorporate it into your EHR and the patient record within your EHR. Again, faxing does not count, and I believe you'll find that you can't really incorporate or consume fax data, all right? We're talking about taking a look at having the meds from another provider come in on that continuity of care document and automatically populate into your EHR so that you can reconcile it usually with a checkbox. So extracting structured data from incoming summary of care documents, directly taking it from that summary of care document and putting it into the patient chart is incorporating patient data. It is consuming patient data. It is interoperability. So this is the whole ball of wax. You need to be able to do this. If you can't do this, or you're getting a 0 in your numerator, we need to talk about it. So the exclusion for this measure is the same as the previous measure 1. You can have fewer than 100 referrals received. If you have less than 100, you can take the exclusion. And of course, there is the broadband availability exclusion, which again, most of you cannot take advantage of. Now, measure 3, reconcile in the EHR. And I kind of jumped the gun with the last one. So you want to bring it into your EHR, and here is where you have to reconcile it. So for more than 80% of your transitions or referrals, you must reconcile that patient data. And so that's what I was describing to you earlier. You must perform the clinical information reconciliation. It is specific to medication, allergies, and current problem list. So you must review that patient's medication, including the name, dosage, frequency, and the route of each med, review their known medication allergies, and review the current and active diagnoses. Now, this should not be something new that you're having to do. So this should not add to the burden. It should relieve some burden of doing this work because it should automatically be populated in your EHR once you have consumed that continuity of care, summary care document. It should automatically be populated. Then you need to go in, or a clinical person within your practice needs to go in and do the reconciliation. So the intent is to consume the new data and then reconcile it and make sure there's no issues with the new data. An exclusion is available if you have fewer than 100 during the EHR reporting period. And we do see, especially specialists, do often, or we do often see primary care have fewer than 100. On this side, we see specialists have fewer on the cent side. So we do have some situations within your practice specialty where we know where you might have some issues with this objective. Okay, just wanted to supply you, because I believe we provide you with these slides, but just wanted to provide you with some definition of terms. Transition of care is the movement of patient from one setting to another. It can include the hospital, primary care, specialty practice, long-term care facility, home health, rehab. It would include all of those, all of your community of health. At a minimum, it includes the transitions of care and referrals that are ordered by the eligible professional or your provider. Your current problem list is at a minimum a list of current and active diagnoses. I think y'all are all used to these, but as they come, as the continuity of care document or that summary of care document comes in, you need to be able to make sure this information is being populated into your EHR. A care plan. I actually have a lot of folks that don't really do a structured care plan, and I just need to highlight this because a care plan may come into play with the 21st Century Cures Act. It's not our charter to go over the 21st Century Cures Act and how it impacts you today, but that is something that does affect you. It is a regulation that is in effect, and you may need to be a little bit more concerned about what's being exchanged with the 21st Century Cures Act and what's being made available. And then the last thing on this page is that summary of care record. Sometimes I call it a continuity of care record. On the technology side, we sometimes call it a CCD or a CCDA, and we've actually got 2 or 3 other names for it. But it's that document that you send that includes the data that it's required that you provide to other eligible professionals or other doctors or providers, clinicians, if you would. That summary of record, believe it or not, should include all of these things. And not only that, but the EP must verify that the fields for the problem list, med allergy list are not blank. Okay, those must be completed. Some of the others, you can have some blanks in and that will be acceptable, but those 3 must not have blanks. This is the best practice, preferred list of data points that should be included on your summary of care data. What does that mean to you? It means you ought to be entering this data into structured fields within your EHR. Most of you are doing all of these. A lot of you are not doing 1 or 2. So we might need to work on that, which is why we're providing this to you today. Here's some additional information, and goodness gracious, most of this is very boring, but this is that part of the specs hardly anybody reads, so I'm going to share it with you. You must have your 2015 edition certification. You had to have that last year. You have to have it this year. And I know the 2015 it seems strange because we're in 2020, but that is the addition that you must have. In order for Measure 1 to count in the numerator, the exchange must occur within the EHR reporting period unless that period is a full calendar year. If you have any concerns about this, please let us know and we'll go over your reports with you. We would love to, as a matter of fact. For Measure 1, the referring professional provider must have a reasonable certainty of receipt by the receiving provider to count the action toward the measure. We have had some issues with this with some EHRs where practices were sending their summary of care documents and it wasn't getting tracked within the EHR on their dashboard. And we found that oftentimes what was happening is they weren't getting a return receipt from the practice they were sending from, so that other EHR wasn't sending the ping, if you will, back. So an EP must have confirmation of receipt or that a query of the summary of care record has occurred in order to count the action in the numerator. Now, let me talk a little bit more about this. Now, there are times when the ping doesn't come back, the response doesn't come back from the provider you've referred to. In that case, you can get an email confirmation. Remember, phone confirmation isn't in writing, and so it will be of very little use on an audit. But you can get a confirmation in receipt from your email in the short term while you work it out with your vendor and that vendor on how to fix this response issue, because it needs to be automatic. If you're not getting a ping and it's not an EHR issue on their end, it might be one on your end. So it's best to figure out what the problem is. The other piece to this is that a query of the summary of care record has occurred. Now, we don't talk to you folks a great deal about queries. And when we bring up the query, we're now referring to that noun, HIE. The state or one of our local HIEs, Health Information Exchanges, you can do a query to the HIE for that continuity of care document, and that your HIE will track your queries, and you could count those in the numerator if you can prove those queries occurred. So again, you might be best to let us help you with this if this is what you feel like you need to do. If you're not part of an HIE and you would like to take advantage of this, especially for this measure, it is a wonderful thing, then let us know. We can help you get working with that. We've actually got some funds available to help you folks out that take Medicaid or are affiliated with practices or take referrals from practices that are Medicaid practices. So let us help you out with that. Again, I'm going to mention the three fields: current problem list, current med list, current med allergy list. Those fields must be populated in order for you to get credit. All right. The other fields, in theory, could be blank and you could still meet the objective, but those three main fields must be populated, and it will impact this measure. And of course, it impacts the second piece, the reconciliation part of this measure. While your EHR may be capable of sending the full continuity of care document or the summary of care document, you must do so on request, and it must be in a specific format. The reason I bring this up is it's not okay. One of the reasons a fax doesn't count is it's not in a consumable format. It doesn't have the right document architecture, if you will, to be consumed by another unlike EHR. So you must have the ability to transmit the specific formatted document from your EHR to another one. You must also be able to transmit data pertaining to lab tests. So this is a little different than what we normally talk about, but your lab tests should be part of the summary of care document, but that information may come in after you've already sent over the summary of care document. And so you just need to make sure that you have that and can make it available upon request. I just bring this up because we often just skip over the lab test issue. And I do believe lab tests are going to become more of a concern for practices as we get further into the 21st Century Cures Act. So just want to make sure all of that's working right now so you don't have to worry with it when the challenge may change. More additional information. The exchange must comply with privacy and security protocols for electronic protected health information under HIPAA. I think I believe one of you, when you registered, had a question that asked about how health information exchange impacted HIPAA or vice versa. Well, it must comply with HIPAA. If you were to join your state or regional health information exchange organization, again, that's our noun, then you would go through a very stringent vetting situation. If you are part of direct, if you can send direct messages to meet this measure, you have gone through vetting for privacy and security, for personal, on a personal level, if you will, a little bit. But you must adhere to all your HIPAA privacy and security protocols. If you're not sure what those are, or you don't even know what those are, then you're not protected and you have an issue. And we need to have an initial conversation about it, and you may need to get some additional help with that. But all the HIPAA rules apply. So in cases where you're sharing information, of sharing a patient, transferring or referring them within your practice, we see this happen a lot in multi-specialty practices. We actually see it happen a great deal when you have perhaps a pediatric practice that expands and adds new providers, and then they start siphoning off or moving some of the patients over to the new provider. We've seen this totally wreck transition of care numbers, or the HIE number, on a dashboard. You have to still work in a manner, so if you're going to send them a transition of care, a referral, even if it's internally, you may do that internally, but you still must send the continuity of care document or you won't get credit for it. So this is a bit of an anomaly. We don't see it in most practices, but we see it enough to be concerned about it. So if this is an issue, or if you're in a multi-specialty practice, or you refer within the practice for whatever reason and your numbers are too low, let's take a look at this. Let's talk about this, and see what the problem may be, and see if it's because you're not doing a transition of care or referral order, if you will, within your system. And again, we talk about you must send that continuity of care document, or that CCDA. We also call it summary of care document, transition of care document. You've got to send it. And the receiving provider must be able to convert it. Now, it's not your problem if they can't convert it. It is your problem if they can't receive it. So we have to, if you've got low numbers, we need to figure out why you have low numbers. And hopefully from these last 4 slides, you've seen that issues can occur in 4 or 5 different places. And sometimes we just need to search them all out. So let us help you with that. We almost enjoy it. All right, more additional information. So when we're looking at the denominator for measure 2, we stated that that information or data could be unavailable. And if it's unavailable, it could be excluded from the denominator. So unavailable would only apply if you requested that electronic summary of care document be sent and you did not receive that document, or if you queried an external source via your HIE functionality, again, that's the noun, and did not locate a summary of care record, or you confirm the HIE functionality supporting query for summary of care documents was not operational in that region. Folks, that second one is not going to fly because we have HIE functionality across the state, unless you're in those little tiny slices of land where broadband, when Mike could figure out a way for you there, but that does not apply to 99.9% of you. So we could use the HIE in support of this measure. And if we've got folks on this call that are struggling to make this happen, we would love to talk to you about how using HIE to make this measure. I will tell you, it is more manual, and that you have to get data from the HIE and you have to get data from your EHR to be able to report for all the measures. So it's a little more complicated, but we can help you get through it. It's not horrible. All right, I hope this is the last additional information slide. Maybe I should have gotten a little more creative. A record cannot be considered incorporated if it's discarded before you do the reconciliation of the clinical information, or it's stored in a manner that is not accessible. So what does that mean? It means that if you upload a continuity of care document, or if you upload it as a PDF and attach it to the file, that will not work. That does not track. That's not acceptable. If you get a fax and you attach that fax or upload it and attach it to the patient record, that is not acceptable. It must be a record in a format that can be incorporated and that you incorporate it for reconciliation. All right, not that is attached. It has to be incorporated. For measure 3, the process could be automated or it could be manual reconciliation. I've seen most practices or most EHRs that I've seen have check boxes, and you go through and check each one, or you can check one box that will automatically check all the other boxes. But of course, this is a clinical situation, folks. It's not about checking boxes. It's about reconciling the information for quality of patient care. So let's keep in mind what the priority is. If there's no updates for measure 3, then you can just do the automatic reconciliation. That's how most EHRs require you to do it. And non-medical staff can conduct the reconciliation as long as they know clinically what to do if there is some kind of discrepancy. So that should be a relief. Your clinicians do not have to do this. All right, now some tips on how to maximize your health information exchange. Okay, so one of the recommendations we have is for you to create a transition of care network. Now this is also called a community of care network. We don't really care what you call it, but we do encourage you to have a formal network. We would like for you to establish a relationship that includes primary providers, specialty providers, hospital, long-term care facilities. We would like you to include all of them in your network, and we can help you with this. Then we want you to engage this community of care or transition of care network. Engage with your partners. Some practices actually have a little one-page memo of understanding that says, we'll send you this information electronically. We expect a response within 48 hours of your visit. We expect you to have these data points. So it may outline some of the requirements that you need to share so that you have an agreement. Everybody understands what everybody's agreeing to. We actually have samples of these if you'd like to use them. They're not required. It just helps with commitment. So we do recommend that you start with partners on the same EHR as you. That'll make it a little easier. But we do find sometimes when you start with the same vendor as your vendor, you don't have to go through all the same steps, and it might get a little confusing when you go outside of your vendor. Contact the practice manager, the care coordinator, the referral coordinator, whomever is managing this piece for the other practice. You may need to talk to all 3 of these people in this organization before you find the right answers. Or you may just give up and ask us if we can help you. But you need to talk with a specific person and have a very, very pointed conversation about what this is, how it's accomplished, and if they have a direct message address. They may not have a clue what you're talking about, and we'll be glad to help you with this introduction and with this education. When you get direct messages, then you're starting to build your direct message directory, if you will, within your CEHRT. So right now, all of you have loaded tables, long ago loaded tables of all the fax numbers that you use for your referrals. We're now creating a table of direct message addresses that we will use in a similar manner, but you got to build the table and then you got to use the table. So that's something many of you have not yet started to do. And remember, eFax works. So when all else fails, of course, eFax is way better than nothing, but it doesn't count. We didn't want to mention that different vendors call their HIE or their internal process or their internal functionality something different. Epic calls it Care Everywhere. ECW calls it P2P. Practice Fusion calls it Ad Referral. I bring this up because I have to tell you that with one of these vendors, we really struggled because the practice was doing the P2P, but didn't have enough vendors. I didn't have enough uh, specialty providers that they were referring to that had eClinical, and just had a heck of a time getting eClinical, understand what they needed to do, and just had a hard time with this. We were able to get this straightened out. We had to have a call with the vendor and the practice, but we were able to figure out where the disconnect was. Sometimes we just have to work it through, folks. Make sure you know how to create that summary of care document. You might create it outside of your normal transition of care workflow. You may do it automatically. It may be created automatically. I hope it's done automatically for most of y'all. Some of you have to attach additional files. Unless we know what your EHR is and we have specific knowledge about your EHR, we usually have to take a look at what's going on in your system to start troubleshooting what the issue is. And that's often best done with your vendor as well. And then you need to know how to send the summary of care document. I have a lot of people that tell me this doesn't work. And then when I ask to see their directory of direct messages, they don't have any. So we need to understand how this works. And then we have to go through the steps to make it work. You could publish to a health information exchange. That's the noun version. And that could count. And if you want to do that, then we can help you with that. And then you could exchange with a secure file outside of these two efforts that we've talked about, which might be more of your P2P methodology for ECW, for example. We'd like to help you figure this out, but figure it out you must. So you need to build a culture of health information exchange. This needs to be something that everybody in the organization understands, needs to work towards. If we need to do a little educational session with your entire staff, we'll be glad to do that for you. Some folks start out by doing internal transition of care summaries between providers within the same organization, just to help get used to it and get some practice. And then you might want to transition to folks that are using the same EHR as you are. It may be much easier to get their direct address from them. And you can also share tips about how you're making this happen. So that has many benefits to it. And then you're going to move to partner with someone with a different EHR, because then you may have a little more difficulty communicating what a direct address is, finding out who their health information service provider is. That's their HISP. And we may have to help them make it work, okay? And I have to tell you that probably 75% of the time we're having to help the other practice make this work. It's not yours, it's their system we have to get work. And of course, you can automate this as a push right out to the HIE and get credit for it. We'd love to have you do that. Don't have many folks doing that in Georgia, but that's eventually what we all should be doing. All right, in summary, yay, everybody's excited. Interoperability is a high priority, folks. That's why we spent so much time on it today and got so nitpicky. The name of the component or this program is the Promoting Interoperability Program. So you can see the name was changed to support interoperability. PI Stage 3 is all about supporting interoperability, both with patients and with practices and with registries, and even with prescriptions in our drug registry, our prescription drug monitoring programs. It's all about information exchange and interoperability. So this Medicaid, PI Stage 3 for hospitals and Medicare, MIPS PI highlight HIE. Okay, it's not just our program that we're focused on today. And then the 21st Century Cures Act, my goodness, it is all about interoperability, exchanging electronic information and not blocking information. And I got to tell you, many of you actually could be doing some information blocking and aren't even aware of it. So that's for another day, but you need to be aware that it is now legislation you have to be concerned about. So this is something that you have to attest to. Is part of interoperability. You need to start educating yourself. You need to be able to exchange information and reconcile and consume it. Remember, you need to plan transitions of care through a health information exchange for care coordination. It is a good thing for your patient. You're not jumping through these hoops just to get this incentive program or just to meet the MIPS requirements or to keep from being penalized. It is a good thing for your patients. Move away from facts gradually. Set some targets. Say you want to get 20% of them done initially, and then move up to the larger amounts. Train your staff on the processes. Give them the education. Test this with your partners. If you didn't test it, don't expect it to work. Work with those folks that you have close communications with that you refer to, and then start working with those that you aren't as close to. You can't expect to change your whole workflow immediately, but if you don't start on the right workflow, you're never going to accomplish the right workflow. So let's get working on it. Next slide, please. I think we're almost done. Yay! I'm now going to hand it over to Ryan Spikes, who's going to talk to us about Measure 8. We can all celebrate. Thank you, Ryan.
Thanks, Liz. You have a question in the question and answer that I think should go to you. I guess we'll answer that after. I just have about 5 or 6 short slides because unlike HIE, we've been dealing with public health for a little bit longer. So most of us are somewhere or we're taking exclusions for public health and clinical data registry reporting. However, I want to make sure we are taking proper exclusions and or attesting as much as we can because public health and clinical data registry reporting is a part of interoperability. So the measure states the EP or eligible provider is in active engagement with a public health agency or clinical data registry to submit electronic public health data in a meaningful way using certified electronic health record technology, also known as CEHRT. There are several requirements for this objective. There's 5 total options, and you must meet 2. And again, like we said with the prior one, you can take exclusions for all the measures that you do not meet, but you must either meet 2 or exclude all of the rest. There is no way you can't meet, an exclusion does not count as meeting the measure. So some people have excluded all 5. It just depends on your practice, and that's what we're here for, to help you know which ones you can exclude and which ones you can add. Measure 1 of Objective 8 is immunization registry reporting, where you are in active engagement to submit immunization data. For Georgia, that's GRITS. And you should have an interface with GRITS and be able to submit this data electronically through your CEHRT. There's several different ways to do that. It is dependent on your EHR. I'm not going to go into them here. That's something you talk one-on-one with your field manager about. Number 2, syndromic surveillance reporting. The EP is an active engagement to submit syndromic surveillance data. Now, as far as EPs, this is only available for urgent cares in Georgia. Urgent care EPs in Georgia, but not all EPs. And there is a statement on the website of the Department of Public Health stating this. However, it also says an ambulatory care physician practices can receive an exemption for this requirement, but must still register with the Georgia Department of Public Health. So the registration form is sent in, is this link here below. It will be in the recorded slides, and we can always send it to you. It is on the DPH website, dph.georgia.gov, and you scroll down to Meaningful Use Stage 3, and you'll find a registry link, and that will take you here. It's a very short survey, takes you about 2 minutes to complete. It is supposed to be done within the first 60 days of your attestation period. However, I suggest doing it immediately as soon as you start counting your numbers or you think you're ready to attest. It can be done prior to your attestation period, but you will start getting emails based on what you select in this in that survey. Measure number 3, electronic case reporting. The EP is an active engagement to submit electronic case reporting of reportable conditions. I'm not going to go very deep into that because it is not available in Georgia either. However, still got to register. So we will discuss that on a one-on-one basis to see if it works for anybody, but it's not available in Georgia. So measure 4 is public health register reporting. Now, this is where most people who do not attest to anything else will find something that they can attest to. These are the public health registries that are available according to the Department of Public Health. And when you fill out the form, you can check that. Also, I'm sorry, my home phone started ringing. Also, if you're on the DPH website, you can find this information about how to email and set up a registry or ask if you are eligible for reporting to any of these registries: the Cancer Data Registry, the Birth Defects Registry, and Alzheimer's Reporting and Related Dementia Registry. These are the email addresses if anybody wants to jot them down, or like I said, you can go to the DPH site and pull this. The Birth Defects Registry, that would apply to most of the OBGYNs, the midwives, and pediatric practices. A lot of them do not report. You have to have more than 10 cases to report it electronically, but you still need to register with this registry if it fits your practice. The other ones, you have to be able to diagnose and treat the cancer and Alzheimer's condition for it to report, for your practice to be responsible for reporting. The best thing you can do if you're unsure is send an email and ask. And they will reply specifically with what your practice does, what your specialty is, and whether or not you should report to these registries. And measure number 5 of objective 8 is the EP is an active engagement to submit data to a CDR. So there are several clinical data registries that you can look at. If you are lucky enough to have Athena does set this up for you, and we can show you where to find this information. Several of my providers do use Dartnet. You can just email and ask for info. However, there's a cost to Dartnet. You can go to the National Institute of Health website and look for a list of registries and find some that are applicable to your practice. Several of them do have a cost. And therein lies the issue. There are some FAQs that do attest to whether or not you should be able to exclude the cost if it does not fit within your practice, because this program was never intended to cause a financial burden to a practice. However, we are finding in audit that they are not really accepting that. So my suggestion is to try and find a registry that you can attest to or that you can report to that either fits in your budget or doesn't have a cost. We can help you go through these registries, find ones that are applicable to your practice. And the last thing you can do is email your professional organizations and ask about public health registries. Now, a lot of specialties don't have registries. And if you go through this NIH list and you don't find anything that's applicable to you, or Dartnet says we don't have any that's applicable to you, that will meet the exclusions we are going to talk about on the next slide. But it's most important that you attempt. So the next slide, please. Now, these are the exclusions. These exclusions apply to all 5 measures of Objective 8. If the EP is not in a category of providers from which, well, this is for the, it says syndromic surveillance, but these exclusions apply to everybody, from which the data is collected in their jurisdiction. So, and then the second one is they practice in a jurisdiction for which no public health agency is capable of receiving electronic information. And lastly, they practice in a jurisdiction for which no public health agency has declared readiness for up to 6 months prior to the start of the EHR period. So when you are taking multiple exclusions, yes, each one of these exclusions apply to each one of the objectives, but you have to figure out when you attest which exclusion respectively applies to you. So if you do not collect the data, for instance, let's say you are the GRITS registry for immunization. Well, your office doesn't do immunization, so you don't have anything to report. You would take exclusion 1. However, if you're attesting to syndromic surveillance and you need to take that exclusion, then you would take exclusion 3 because you are in a jurisdiction where no agency has declared readiness. So there are, and we will help you on a case-by-case basis. It would be a lot to try and get into how these things apply individually and cover all or possible scenarios because there are so many. It's almost like mixing up numbers. You can just have 3 numbers, but you can get a whole lot of options out of those 3 numbers. So it's best to talk with one of your clinical reps and we will help you pick which exclusions, which registries, or attest which registries you should attest to or report to. It's best if you can report to 2 and not take any exclusions, but if you must, we will help you take the right exclusion for the right measure. So how do you report? This is considered a yes/no report in MAPIR. So that means you must have some proof as to the emails that you've sent, the testing that you've done, and or the registries to which you are reporting. So there's 3 different levels of engagement, and you have to attest to which level of engagement are you in. Have you completed a registration? Are you currently in testing and validation? Are you in production in which you're exchanging information from your CEHRT to the registry? So now you need the proof of exclusion. You also need proof of which engagement stage you are in. If you're attesting yes, if you're testing no, you need proof of the exclusion. Again, you must meet 2 of the 5 measures or exclude all measures that are not met. So you either have to meet 1 and exclude 4 or exclude all 5. But an exclusion does not count as a yes. So you have to exclude everyone you can't attest yes to. So again, a little summary of what you should do. Go fill out the survey. Everybody needs to fill out the survey. You can review the information, like I said, at dph.georgia.gov. That's where you can find all the emails that you can send, and keep the emails, keep copies of all of the emails sent and received. That is your best time-stamped proof of your efforts to report to the registries. And you can also, if you are reporting to registries and are currently registered with GRITS or whatever registry, you can use screenshots of your uploads as proof of your yes. And again, these are the places where you can find the registries. You can check the CDC, NIH, Dartnet is a good one, or email your professional organizations to ASH about specialty-specific registries. And I think that's my last slide. Can we go to the next? Okay, I'm going to turn it back over to Selena.
Thanks so much, Ryan and Liz, for all of that valuable information. Before we move to the question section, I just wanted to provide a few announcements. My first announcement is our featured class in partnership with Format Approved. Hybrid Solutions partners with Hybrid Format Approved to provide its members with discounted training, continuing education, and professional development. The featured class for this month is Certificate of HIPAA Proficiency for all healthcare staff. The CHWP course provides annual HIPAA training for all professionals in healthcare who come into contact with protected health information. To sign up, use the link below, and please use the coupon code HIGHBRIDGE20 to receive a 20% discount. We also have another new and exciting announcement coming from Internet Essentials from Comcast. Internet Essentials from Comcast brings you affordable high-speed internet so your kids can learn from home at the low rate of $9.95. Apply today if you qualify for programs like National School Lunch Program, Housing Assistance, Medicaid, SNAP, SSI, and others. For more information, please visit www.internetessentials.com. All right, ladies, so we do have one question that is inside of the Q&A box, and I will read the question as follows. Working with a practice that has an EHR that belongs to direct trust but doesn't pay dues, so practice can't use HIE functionality too easily, send referrals electronically, and other providers are not using the old direct messaging functionality. How would they be able to satisfy this objective? And that could go to anyone.
This is Liz. I'd like to take that question if I may.
Absolutely.
I'd actually love to talk with this practice and make sure that I understood who's not paying the direct trust dues. Is it the EHR or is it the practice? But there is a solution regardless. In the state of Georgia, GHIN, which is our state health information exchange, does provide a free direct address. So we can get you a direct address. We can get practices that you send to, or receive from. We can help them get a direct address. It is right now still provided free in the state. Our Medicaid program with DCH does a great job of supporting these efforts for us and help paying for some of these efforts that we're working on. And so they provide the direct address for free. A little bit of manual on how you track it. When I say manual, you're going to get data from both the HIE to use, and you'll have to rely on your dashboard for your other measures. But we can help you out with this one, and you can get this one done. I'd still like to resolve the issue within your EHR, but in the meantime, we can get you exchanging via direct, and we can help the practices you send with as well.
Thanks, Liz. I hope that was able to answer your question. Okay, we have a few questions that were submitted previously. So let's see if we can answer some of these the best we can. What HIPAA requirements apply to HIE and registries?
Well, we actually brought this up in our webinar today, that all of your HIPAA requirements apply to health information exchange and to registries. And you actually go through some vetting. They mentioned direct trust in that last question, and that is some of the vetting process for direct. It just depends on how you go about it, whether you get charged for it or not. But you must utilize all your HIPAA requirements. All of them apply. You must be secure and initiate security and privacy in all of these efforts.
Thanks, Liz. I just wanted to kind of reiterate that just in case somebody had missed that. Last question. How can more physicians participate with an HIE or public health registry?
Oh, I love that question. There's multiple ways that you can participate with a health information exchange or an HIE. We'd love for you to contact us and let us see what looks like the best method for you, what works best with your EHR. And I think that Ryan did a great job of talking to you about where you have to go to work with your public health registries. We would love for everybody to be in a situation where this is electronic between your system and the registry, as we have with grants, with immunizations, but we're not there yet for all of them. So again, we'd love to help you out with that.
All righty, that seems to be the last question. If there are any last minute questions, I'll give you maybe a minute or so to drop them in the chat, but if there's no more questions, I'll move forward. Here are some additional resources and how to reach us. We would like to thank you guys for joining today's webinar. Please remember that we host our monthly webinars every third Tuesday of each month from 12 p.m. to 1 p.m. And we would like for you to save the date for Tuesday, November 17th, 2020. If you would like to contact us, please contact our program manager, Selena Williams, at sewilliams@msm.edu. Her phone number being 404-752-1193. Thank you all so much for joining, and I hope you have a wonderful day.